And I would like to introduce Janet, who's doing a presentation on the lymphatic system, the impact of the disease, and lots of tips on how to manage it. Janet is a physiotherapist and a certified decongestive lymphedema therapist. She has been doing this work for over 25 years. She was recently working in Kelowna, and now she's working out of Vancouver at the Go Physio. She volunteers her time as well on the BC Lymphedema Association on the Medical Advisory Board. And she's also a clinical assistant for the UBC Adult Oncology Lab. So please, if you can mute yourselves, we'll let Janet start her presentation.
Great, thank you, Sandy. And thank you everyone for taking the time to join us tonight. So I'm going to spend the next hour or so talking about lymphedema, what it is, why people get it, differential diagnoses and how to manage it. But before we get into all that, I think it's important that we go over the anatomy of the lymphatic system. It'll help you understand better why we manage it the way we do. So the lymphatic system can be considered a subsystem of our blood system or our circulatory system. So it's a network of lymphatic vessels, lymph nodes, and small organs, mainly the tonsils, the thymus, and the spleen. And they're responsible for producing lymphocytes or immune cells. So there's three main functions of the lymphatic system. The first one is to maintain fluid balance. So in a 24-hour period, approximately 6 to 8 liters of fluid leaks out of our blood vessels into our interstitial spaces, so into all the spaces between our cells. And the lymphatic system picks up this fluid, brings it to regional lymph nodes where it's cleaned, and then other lymphatic vessels bring it back to the subclavian veins into the blood system again. So in a 24-hour period, approximately 6 to 8 liters of fluid is picked up by the lymphatic system. So that's an important part of lymphedema, is the maintaining of the fluid balance of the lymphatic system. We're going to talk about that quite a bit. The second big function of the lymphatic system is immunity, the immunological functions. So the lymph nodes contain immune cells that recognize and respond to foreign invaders, attacks them and destroys them. And then the liver and the kidneys then get rid of all this toxin material. And then the third factor is, or the third job, so to speak, of the lymphatic system is that it absorbs fats through the intestinal lymph vessels in the gut and returns fats to the bloodstream, either for storage or use. So when it comes to lymphedema, the maintaining of the fluid balance is the main role that we're concerned about. So to look at a diagram of the lymphatic system, you can see all the lymphatic vessels and the lymph nodes. This picture doesn't show the head and neck having lymphatics, but it's full of lymph nodes, lymphatic vessels as well. And then, of course, it's got the help of these small little glands that produce lymphocytes or immune cells when it's needed. So if you were to sort of superimpose the lymphatic system on top of this picture, you can see that the lymphatic vessels run very closely in proximity to our our blood vessels. So the one big difference between our circulatory system and our lymphatic system is that our circulatory system is a closed system or a two-way system, and it's pumped by a big muscle, which is our heart. So our heart pumps the fluid through the arteries, bringing, of course, oxygen to all parts of our body, and then the veins bring it back to the heart, and this is a closed system. And then the lymphatic system are just a little bit of a subsystem that takes up the fluid that's been leaked out of these vessels and directs it to regional lymph nodes. So the lymphatic system is a one-way system. It does not have a heart that pumps the fluid. So it relies on extrinsic factors, mainly muscle contraction. So our muscles that are surrounding lymphatics, they help propel the fluid. Deep breathing, respiration, that helps propel fluid. Pulsing from the neighboring veins and arteries. Peristaltic contractions, and food moves through our gut and stimulates those lymphatic vessels in our gut. And manual lymph drainage, which we're going to talk about in a minute. So those are the extrinsic factors, but what the main intrinsic factor is the shape of the lymphatic vessels themselves. It's comprised of these little lymphangions that have special little valves that are able to allow fluid to go through, and then they close and the fluid can't go backwards. It then goes forward through the next little vessel, which closes and moves only in one direction. So we have about 600 or 700 lymph nodes in our body, and they are divided into different regions of the body, which we're going to talk about shortly. There are various sizes from about 2 millimeters to about 3 centimeters in size, various shapes, and their main purpose is to filter. They also absorb water, regulate protein concentration, and then of course they store white blood cells and our immune cells. So when we talk about regional lymph nodes, the lymphatic system is divided into territories, which means these lymphatic vessels, they direct fluid to regional nodes. So you can see from this diagram, we have a whole group of lymph nodes in our neck on each side, our supraclavicular lymph nodes. We have a large group of lymph nodes in each axilla. We have a large group in each groin, and then this picture doesn't show it, but we have a whole bunch of lymph nodes in our gut, deeper lymphatics. So the superficial lymphatics, the ones that we're using when we're doing our manual lymph drainage, which run just below the skin, they have the ability to cross these imaginary dividing lines. So if you look at a group of regional lymph nodes in the right armpit, for example, all the fluid that the lymphatic system picks up from the surrounding interstitial spaces brings the fluid to those regional nodes. So the right axillary lymph nodes draws fluid from the whole quadrant, from approximately your clavicle to your midline to your waist, and brings the fluid to those lymph nodes where it's cleaned, and then deeper lymphatics bring it back to the blood system. So of course, the ones in the other side drain the fluid from this region. The ones from the left groin drain the fluid from the waist to the midline and the whole leg, of course, front and back. Same with the opposite side. The right side head neck drains to the supraclavicular lymph nodes in your neck. And of course, same with the opposite side. So the superficial lymphatics, fortunately, have these lymphatic vessels that are able to cross these imaginary dividing lines and go up to the neck lymph nodes on the same side, across to the lymph nodes on the opposite armpit, or down to the lymph nodes in the groin on the same side. So when we're doing our manual lymph drainage, we're thinking about this anatomy, and we're trying to figure out which group of lymphatic vessels we can redirect fluid to that have not been impacted. So in a healthy lymphatic system, this 6 to 8 liters of fluid circulates through all these lymphatic vessels, goes to their regional nodes, is cleansed and returned back to the blood system. In lymphedema, though, there's an imbalance in the rate that the lymph is being produced and the removal of this fluid. And this causes a backup of fluid into that particular region. So the ability to transport fluid or the transport capacity is lower than the amount of fluid that actually needs to be transported. And we get a fluid backup in that region. So we get a little bit of a car crash, a little bit of a traffic jam. So I've got two definitions of what lymphedema is. They both mean the same thing, but one's a little bit easier to understand. So it's a chronic swelling in a body part due to the backup of interstitial fluid into that body part due to some sort of damage, malformation, or obstruction of lymphatic vessels or lymph nodes that normally transport the fluid. And lymphedema is an abnormal accumulation of protein-rich fluid in the interstitium, which can cause chronic inflammation and reactive fibrosis of the affected tissues. So what are the signs and symptoms of lymphedema? Usually it's a gradual onset. It's not really painful, it's more discomfort is a common description, heavy, tight, achy. It can be pitting edema, which we'll talk about. In the legs, it often starts distally with a squaring of the toes and a positive stemmer sign and loss of the bony prominences. If it's bilateral, it's usually not symmetrical. It's usually a little bit different on each side. And it can be more common to develop a cellulitis or a skin infection in a lymphodematous limb. So when we're looking at the stages of lymphedema, stage 0 is when there's actually no visible sign of swelling, but people may just start to feel a fullness, a heaviness, a tightness, particularly after activity, an exercise class, gardening, traveling. That goes away. They may not even think about it again, and then that may happen again. That to me is a sign that the lymph fluid is going through, it's being transported through okay, but maybe it's taking a little bit longer than it normally would. So that could be a sign that the lymphatic system is being taxed a little bit. So you kind of want to pay attention to that if you're starting to notice this heaviness, fullness, tightness on the affected side, different than the other limb. Stage 1 then is when you can actually start to see some swelling, whether it's in your hand or around your elbow or in your ankle, wherever your lymphedema is. And then usually it's not going away. And at this point, you definitely want to start addressing it with some manual lymph drainage and consider a compression sleeve. And then stage 2 is where it's becoming more advanced and it's requiring a little bit more intensive treatment and probably some compression bandaging to soften and reduce the size of the limb. There's increased risk of infection, but usually it's still pitting. And when we talk about pitting is when you can kind of push down into your leg or your arm, wherever your lymphedema is, and you hold it for about 10 seconds. And then when you release it, it takes longer for that dent, so to speak, to go away. Normal tissue should rebound quite quickly, but when there's lymphedema, it'll take a little bit longer for it to go away. You can see in that picture there. Stage 3 then, of course, is when it's quite significant and fibrotic, no longer pitting, very high risk of infection. So here's a couple of examples of stage 1 to stage 4, as well as the leg. So as you can see, it can progress if it's not treated. So it starts with a lymphatic impairment, protein-rich fluid builds up, and that can become a chronic inflammation. If this isn't addressed, then the connective tissue can change and become more fibrotic. And if this is left untreated, that can actually turn in almost to like a fatty deposits. This can then impact the remaining lymphatics surrounding it. Skin changes can occur, and of course, the infection risk is higher. So lymphedema is classified into two different types, primary and secondary. So let's talk about primary first. So primary lymphedema is when you're born with some sort of imperfect development of the lymphovascular system. Swelling can be present at birth, or it can occur later in life, often around puberty or after pregnancy, but not always. It can be familial or hereditary. It may be part of a genetic syndrome, and it's a little bit more common in females than males. So in these cases, there's some sort of developmental abnormality in the lymphatic vessels. Most often it affects the legs, but not always. So the most common types of little abnormalities in these lymphatic vessels are hypoplasia or hyperplasia. So hypoplasia is the most common malformation, and that's when there's an incomplete development in the number of lymph vessels or lymph nodes, or the size of these lymphatic structures is smaller than normal. So you've got these lymphatic vessels, but either they're too small or there's not a normal number of them. And so your body isn't able to cope with the normal amount of lymphatic fluid. Hyperplasia, there's a structural malformation of lymphatic vessels or lymph nodes, such as an enlargement of the lymphatic vessels, resulting in the malformation of valves. So these valves may not be able to, when I talk about those little lymphangions that have these special valves, maybe they aren't developed properly, so fluid can kind of go back rather than being propelled forward. So that compromises the flow of the lymphatic fluid. It can back up. And then there's a rare cause called lymphatic aplasia, where there's just an absence of lymphatic vessels or nodes in an area. This doesn't happen as much. More common, there's just a bit of a maldevelopment in the vessels that are present. So primary lymphedema, so there's a maldevelopment of the lymphatic system in primary lymphedema. It can be inherited, which means it can pass from generation to generation, and that's called Milroy's disease. There's several genes that can be involved in the development of the lymphatic system, and if there's a mutation of some of those genes, it may cause lymphedema. And there's also many syndromes, such as Klippel-Trenaunay, Turner-Noonan, where one of the components is a lymphedema as part of this syndrome. It can affect any age, gender, and race. And we treat primary lymphedema and secondary lymphedema fairly similarly. So let's touch on secondary lymphedema now. The most common cause of secondary lymphedema is breast cancer treatment, but it can be secondary to any cancer treatment where lymph nodes have been removed and are radiated. See lots of patients with head and neck lymphedema, gynecological cancers where lymph nodes are removed and radiated. They'll get swelling down into the legs. Melanoma is another one that spreads to regional lymph nodes, and they may have to be removed and treated. So that's another common cancer where we see lymphedema. So the risk factors of secondary lymphedema are the extent of the lymph node involvement and the number of lymph nodes removed. Axillary node dissection, of course, takes more lymph nodes than a sentinel node biopsy. So you'd be a little bit more at risk if you had more lymph nodes removed from an axillary node dissection. The extent of the radiation to remaining lymph nodes can affect your risk of lymphedema. We know now that radiation doesn't really impact the lymphatic vessels, but the fibrosis from the surrounding tissue can compress the lymphatic vessels below it and increase the risk of lymphedema. We do know, though, that the lymph nodes are highly radiosensitive, so remaining lymph nodes if there's been radiation to them, they can develop a little bit of scar tissue and not be as effective at moving fluid through. There's some evidence that a significant post-op infection can increase the risk of developing lymphedema. There's some evidence that a body mass index of greater than 30, so obesity, there's some evidence for that. And there's a little bit of evidence that taxanes may play a role in lymphedema, chemotherapy. So let's just talk a little bit about differential diagnoses, so other forms of swelling that can occur. The ones I'm going to touch on are lymphedema, chronic venous insufficiency, and congestive heart failure. So lymphedema, it occurs mainly in women. It's considered a fat disorder and a connective tissue disorder, where there's collagen abnormalities that affect the way the fat cells expand. There's often hypermobility of the joints. It's bilateral and symmetrical. So that's a little bit different from lymphedema when we're trying to diagnose a lipedema. Sometimes they can look a little bit similar. Usually, well, we know that lipedema is bilateral and symmetrical. And it usually goes from about our hip bones, our iliac crest, down to our ankles, and it can actually have folds over at the knees and the ankles. But interestingly, the top of the feet, the dorsum of the feet, are usually spared of swelling, unless it's progressing into a lympholipedema, which means the lipedema has started to compress the little lymphatics below, and now you're developing a little bit of lymphedema on top of the lipedema. Stemmer sign is negative. I'm going to talk about stemmer sign in a second, whereas stemmer sign is usually positive in lymphedema. There's usually little or no pitting. We talked about the pitting. You don't really see that in lipedema, but you can feel nodules in the tissue. There's no cellulitis infections often in a lipedema limb. And it's painful. It's painful to palpation, and it can bruise easily. And there's some evidence that it's painful because perhaps the little peripheral nerves are being impacted. There's more evidence is coming out now that proper diet and exercise can have some benefit. I know the BCLA has had a couple of guest speakers, nutritionists, so they might have more information on where to look for that. And there's some evidence that manual lymph drainage can help with the pain, and that light compression can help manage the pain as well. So stemmer sign is often used in kind of assessing whether a limb is lymphodematous or not. And that's where you just sort of pick up the tissue at the top of the toe, the top of the finger. I even use it on the forearm compared to the other arm, the thigh compared to the other thigh. And it's where it feels thick and it's hard to lift it up compared to a limb that does not have lymphedema. I'm not sure if you can see from this picture here, but you can see it's a bit thicker on this side where she's trying to pick up the tissue, and here it's not. And you can see where this one, if she was trying to lift up the toe tissue, it would be thick and harder to lift up. So that's a test that's often used. If you hear that word stemmer sign, that's what they're referring to. Chronic venous insufficiency. So this is another type of problem that causes swelling in the legs. This is more of a venous problem. So a venous reflux where the valves in the legs don't function properly, and it's the blood that's pulling in the legs more than the lymph fluid. And then you can get swelling in the lower legs and ankle, especially after extended periods of standing. The legs feel heavy, tired, achy, or restless. Varicose veins might develop. The skin often looks leathery. flaking and itching of the skin. You can get venous ulcers that have a hard time healing. They're generally around the ankle, and they can progress to what's called the phlebo-lymphedema. This fellow here, this was the first patient I saw when I came back from getting my certification in 1997. I was like, oh my goodness, what am I going to do to help this fellow? But I just followed everything I learned about decongestive therapy for lymphedema, and you can see he did well. So I think he had a phlebo-lymphedema. So I think he had some venous insufficiency on top of lymphedema. You can see the wounds finally started healing once he got compression, and he did very well. So congestive heart failure, that's a chronic condition that affects the pumping ability of the heart and the accumulation of blood in the lungs and the legs and the feet. You have shortness of breath, and lower leg swelling is one of the common signs. It's usually treated with medication and lifestyle changes, possibly surgery, and not manual lymph drainage. So therapists who's taking their training, that's why you need to see someone that's certified so they understand the different types of swelling that people can get. So how do we manage lymphedema? Complete decongestive therapy is still considered the gold standard for managing lymphedema. And it consists of 4 components: manual lymph drainage, compression therapy, remedial exercises, and meticulous skincare. And we're going to go through each one of those. So if you do have lymphedema and you are wanting to get some treatment, you know you need some treatment, you really do want to try and find a certified lymphedema therapist. So this is a licensed health professional, PTOT nurse, registered massage therapist that have 135 plus hours of specialized education. There's a lot of cosmetic type estheticians out there that do lymph drainage. They don't know the anatomy and the physiology like someone that's certified does. So if you're just going for basically a light massage, that's one thing. But if you're going because you have lymphedema, then you want to make sure you have a certified lymphedema therapist. So let's start with manual lymph drainage. So it's a manual technique aimed at rerouting the flow of stagnated lymph fluid around blocked areas into more centrally located healthy lymphatic vessels, which will then drain back into the blood system. There's a working phase and a resting phase in each stroke, and this results in an increase in lymphatic activity in the healthy areas, creating a suction-like effect through these little lymphangions, which we talked about, and directing fluid away from the area of congestion to areas that have not been affected by any problems. So again, we're back to our little lymphangion, and we are directing fluid with our hands manually through these little vessels, which then close, and the fluid propels forward. The one-way valves contract 10 to 12 times per minute, and they have smooth muscle alongside them that helps with this propulsion of fluid. So I'm just going to show you this little video. This is a healthy lymphatic, and it's going to show you before manual lymph drainage has started, and then it's going to show you once manual lymph drainage has been started. So there's no sound or anything. It's just going to, let's see here. So I like this little video because at the end, you're going to actually see the therapist's hands doing the manual lymph drainage. So now MLD has started. And you can see the fluid moving. This is magnified, I don't know how many times, but you can see the fluid moving through the little lymphatic vessels. And in a minute, you're going to actually see the therapist's hands. Can you see the hands at the bottom there? So when we say there's a working phase and a resting phase, the working phase is moving the fluid. The resting phase is when we relax our hands. It propels through the vessels. I hope you got to see that okay. So when don't we do manual lymph drainage? What are the contraindications? If someone has a cellulitis, and it happens occasionally when someone comes in and says, oh my gosh, not sure what's going on with my arm or my leg, it hurts, it's red. Yeah, you have a cellulitis. We can't do any treatment right now. You need to go get on antibiotics right away. We need to manage that. So when someone has an acute infection, manual lymph drainage stops until they've been on a course of antibiotics. The heat, redness, pain has gone away. Untreated congestive heart failure or cardiac edema. If you suspect that you have a heart that is not functioning properly, see your physician. If you're experiencing any symptoms of heart failure, do not receive manual lymph drainage. An untreated deep vein thrombosis. Often when someone has an onset of lymphedema, especially if it comes on relatively suddenly, a limb is swollen, the doctor will always refer you to make sure it's not a blood clot, because we don't want to risk moving a blood clot with our manual lymph drainage. Once it's been treated, we can go back and do that. Once you've been on anticoagulants and it's been managed. A relative contraindication is malignant disease. I've seen many patients, though, that we treat who are palliative, but have a very swollen arm or leg or whatever. And we treat it more for comfort. So that's why it's considered a relative contraindication. So back to this diagram. When a manual lymph drainage therapist assesses you, she's thinking about this diagram. She's thinking about where the traffic jam is and what alternative pathways we can use to redirect fluid away. So if we take, for example, a right upper quadrant surgery, radiation, lymph nodes removed, backup of fluid in this quadrant, we're going to try and redirect fluid up to through these tiny little anastomoses towards lymphatics in the neck on the same side, across the chest wall to the lymph nodes on the opposite side, or down to the lymph nodes in the groin on the same side. So for example, if someone has had primary lymphedema, for example, affecting their left leg, we will try and redirect fluid up towards the armpit on the same side, possibly across to the lymphatic vessels in the groin on the opposite side, and we'll definitely try and stimulate as many of the lymphatic vessels deeper in the abdomen. So when someone has very mild lymphedema, stage 0, maybe even stage 1, they probably don't need compression bandaging. But if someone has enough swelling that we need to reduce the size of the limb, they need compression bandaging. So we will do a lymph drainage treatment, and then we'll apply compression bandages. And this is used to reduce the size of the limb to maintain the effects of the manual lymph drainage. When we're trying to reduce the size of the limb, the bandages are worn 24/7 for anywhere from 2 to 4 weeks. They're only removed to have a shower, then put back on until the limb reduces enough in size and has plateaued. And why do we do this? Because the lymphatic system is unable at this point to perform one of its basic functions, which is the removal of water and protein from the tissues of that area. So even after successful MLD, manual lymph drainage, the affected body part is still at risk of reaccumulating that fluid. So it needs external compression from compression bandages to provide the necessary support for those tissues that have lost their elasticity and compensating for the elastic insufficiency by putting increased tissue pressure so that those lymphatic vessels that have become a little bit weakened have this external pressure so it doesn't reaccumulate. So I'm getting a little tongue-tied there. So the external compression of these compression bandages, it basically provides a counterforce to the working muscles known as working pressure. So we don't apply compression bandages for someone that has untreated congestive heart failure, uncontrolled hypertension. Again, if they have an acute cellulitis, we hold off on the bandaging until it's been treated. If they have peripheral arterial disease or arterial wounds, we do not apply compression bandages. So here's a patient of mine that had melanoma, and his arm was left untreated. It affected his axillary lymph nodes, so he had to have axillary lymph nodes removed and extensive surgery. It was left untreated for a long time, and then he actually worked as a grocery clerk restocking, and it got to the point where his arm was almost as heavy as some of the boxes he was trying to have to lift. So he finally was able to try and find some treatment. So in his case, he lived over an hour away and really couldn't come in more than twice a week. So we opted for Coban. So we did an hour of manual lymph drainage, or 45 minutes or so of manual lymph drainage. We wrapped his arm in Coban. He went home for 3-4 days. He came back. We removed the Coban. We washed his arm. We did another manual lymph drainage treatment, rewrapped it, and we did this for, I think, 3 weeks. I would have liked to have done another week, but he lived far. Financially, it was very difficult. So he managed to do 3 weeks and responded very well. And then went from that into still trying to bandage at night and went into a daytime garment after that. So here's some examples. There's lots of different nighttime garments now, but once you go through that phase of 2 to 4 weeks of the continual bandaging, then you have to figure out what's needed to try and maintain that. Ideally, patients are still bandaging their limb at night and wearing some sort of compression during the day in the form of a compression garment. Sometimes it's really hard for people to bandage, especially if it's 2 legs or 1 arm and it's not their dominant arm. So there are these alternatives that are not a bad option to wear at night. This is a Crecia garment, and you can actually add maybe 1 compression garment on top of that, or compression bandage on top of that, which is a little easier than trying to do your whole limb. So there are options out there. But ideally, when you go from that intense phase of 2 to 4 weeks, you still need to keep doing something until your body starts to maintain. And hopefully down the road, you might be able to skip the odd night or so on, but everybody's different. And it's just something that you wait and see how your body's going to respond. So when it comes to garments, you really do need to try and see someone that's certified to measure you properly, because an ill-fitting garment is going to do more harm than good. So usually when you're looking at a garment, it's a graduated pressure where it's highest down at the wrist or ankle, and then it gets a little bit less intense pressure as it goes up towards the groin or the axilla. And you need to have the right fabric for the stage of swelling. There's circular knit versus flat knit. Circular knit we tend to use for very mild compression, where we're not trying to contain the size of a limb. If you're trying to contain the size of a limb, particularly if you're a person that their limb kind of keeps wanting to get bigger, then you definitely need a flat knit garment. A circular knit's only going to bind and cause you more harm than good. You want to make sure you have the correct compression class. It should feel snug, supportive, and comfortable. It should not dig in and fold, causing pain. You should have it check your measurements checked at least once a year, just to see that you still are in the right size. An improper fit can make the lymphedema worse. Sometimes, especially for legs, you might need a little bit of adhesive glue to help it stay up, because when you're walking or exercising, it can kind of slip. And then if it starts to kind of bind at the knee, then that can cause more trouble. So sometimes a little bit of adhesive around the top of the thigh band can keep it from slipping. If you just are unable to don and doff these garments, particularly for legs, you can opt for a Velcro option now. There's lots of different ones on the market. So sort of the general rules of thumb for looking at a garment: 15 to 20 millimeters of compression is for minimal lymphedema or prophylactic, where you don't really have any signs of lymphedema, or maybe stage 0, but you might be at risk because you know you've had lots of lymph nodes removed or radiation. 20 to 30 is when more of a stage 1, where you do probably have a little bit of mild lymphedema. Often a circular knit might be enough if you're not trying to contain this swelling. You may need, though, a flat knit at that stage. That's where you kind of need to see a therapist and a proper fitter. 30 to 40 millimeters of compression may be needed for a stage 2 arm, and it's often needed for legs. And then stage 40 plus is sometimes needed for lower extremities, for those who are used to wearing a lot of compression and stand and sit for prolonged periods. So the circular knit is, again, more for mild lymphedema or prophylactically when you don't really have it, but you're a little bit concerned. Flat knit is when you're needing to contain the swelling, and a circular knit just has not worked for you well in the past. Velcro type is a good option when you're unable to get a garment on and off very easily for whatever reason, arthritis in your hands or whatever the reason may be. So here's just a couple of different kinds of night compression. When I worked at the cancer agency, I saw so many head and neck cancer patients, and I kind of would make these little garments to try and contain any swelling below their chin and into their neck region. Some people do have swelling in the trunk area, so there's garments for that. Okay, I just wanted to touch on breast lymphedema because we do see it quite a bit in our lumpectomies. So it's more common when the lumpectomy occurs in the upper outer quadrant of the breast, and it's probably because some of these prepectoral or external mammary nodes may have been removed when the lump was removed. And the signs and symptoms are breast swelling and discomfort. It can become firm and tender. It's usually a little bit more painful than an arm or a leg lymphedema would be. And I think because we have our muscles in our arms and our legs to help with that propelling of the lymph fluid, the breast doesn't have that. So it really does just pool and sit there, and it can be quite painful. And often I notice when someone has breast lymphedema, the tissue even becomes like a light pinkish color, which is concerning for people. But the good news, it responds really well to manual lymph drainage and compression. Here's a couple examples of a couple of my patients who had some breast lymphedema, and you can see where her bra or garment or whatever was kind of digging in more on the affected side. And this lady didn't really have any lymphedema in her arm, but she just had this pouch of swelling that just kind of was really annoying to her, right up in here. So here's an example of a type of compression that you can use, a swell spot. So again, it just helps redirect fluid away from where it's pooling in the breast towards alternative pathways. And you can hold it in place with a compression bra or even like a Spanx type camisole will hold it in place, something like that. You can sleep with that on. This just goes in the washer and in the dryer and can be reused. And if you were to feel it, it's got little pieces of foam that helps kind of compress the swelling so that and softens it as if it's become firm, or keeps it from becoming firm so that the fluid can be moved manually and redirected better. Okay, so the third component after manual lymph drainage and compression bandaging is meticulous skin care. So when we're doing our manual lymph drainage, we're mostly focusing on the superficial lymphatics that are just below our skin. So our skin then is our first barrier of defense for our lymphatic system. So a lymphodematous limb is at high risk of infection. Stagnant lymph has increased protein molecules, which make it a milieu for bacteria to grow. So we want to take care of our skin. We want to avoid burns, cuts, scratches. Don't want to make people scared, but you just want to be aware that if bacteria gets into a limb that has lymphedema, you're more vulnerable to getting an infection. So we still do follow the National Lymphedema Network guidelines for avoiding needles, blood pressure cuffs on the affected limb. We're still kind of following those. I know there's some people, some doctors that'll say, oh, don't worry about that. If you have a choice, I say use your other limb. If you don't have a choice and you don't have any signs of lymphedema, it's probably okay. But you just want to be aware. So you want to keep your skin moist and clean. So if you look at healthy skin, it's able to fight off any pollutants in the air, any bacteria if you're out gardening. But if you have dry, rough, dehydrated skin, these bacteria, little molecules can penetrate and put you more at risk of developing an infection. So you want to cleanse after every bandage and garment change. You want to apply moisturizer to keep your skin hydrated, and you want to do your best to try and avoid developing an infection. I've seen 2 breast cancer patients in my many years of treating lymphedema that had recurrent cellulitises, meaning at least 2 to 3 times a year they developed a cellulitis. And both those people, when we applied the compression bandages, when I removed the bandages 3 days later, there was actually an odor in their arm or in these bandages. So that made me realize that that infection never totally resolved. It was under control with the antibiotics, but it never really went away. It was just kind of at bay. And once they did intense phase of compression bandaging, they never got an infection again after that. So if you are a person that's getting recurrent cellulitis, you would probably benefit from an intense phase of CDT, meaning the manual lymph drainage combined with the compression bandages 24/7 for 2 to 4 weeks to try and get that stagnant fluid out of there and get rid of that infection once and for all. So the fourth component then is remedial exercise while in compression. So we talked about these extrinsic factors that help propel lymph fluid through these little lymphangions, and muscle pumping is one of them. So when you have your compression garment on, simple movements, lifting your arm, compressing, squats up and down, sitting up and down on your chair, ankle pumps, all these help the vessels propel the fluid. So these exercises are recommended to be done daily while in compression. They aren't difficult. They're just simple, basic exercises to help your muscles against the compression propel the fluid a little better. So when we talk about exercise and lymphedema, Catherine Schmidt was one of the first people to do a big study way back in 2009 that showed that exercise did not increase lymphedema. They were able to kind of show some evidence that slow, graduated increase in strength training did not increase or cause lymphedema, and in fact may make lymphedema, if you have it, better. So what we're trying to recommend to patients is, yes, exercise. We want you to exercise. We want you to be as normal and functioning as possible, but it just has to be a slow, graduated progression of strength training. See how you do. If everything's fine, usually I recommend patients, if you're, say, for example, doing 2 sets of 10 at 5 pounds, rather than going to 2 sets of 10 at 8 pounds, perhaps start with 1 set of 10 at the 8 pounds and still maybe do 1 set of 10 at the lighter weight, and just see how your body responds. So I have seen people run into a little bit of trouble more if they're doing sudden heavy lifting. So for example, let's clean out the garage and you decide to push a big couch, that kind of thing. That's the kind of thing I'd maybe be a little bit careful with. If you've been already doing a graduated strength training program on a regular basis and your legs and arms are strong, you'll be able to tolerate more of that. But if you haven't and you're not really an exerciser, to do a sudden heavy lifting, from my experience, could be a little bit of a risk for bringing more fluid to that muscle, which brings more fluid to the lymphatic system, and your body may not be able to move the fluid out as quickly. So just be a little bit careful with a sudden movement, especially if you're not one that's already been gradually increasing your strength. So we get asked a lot about pneumatic compression pumps. When I was first trained, they only had the old style of compression pumps that just went to the groin or just went to the axilla. And I did see a couple patients that had used them for many years. And the one that I'm thinking of in particular, she used a pump on her leg for many years. It just went to the groin, and her whole groin area was so fibrotic because the fluid was never redirected to alternate pathways. Now the pumps are better and include the whole quadrant. So, I mean, they're rarely effective as a first treatment or a standalone treatment for lymphedema, but they may be helpful in the self-care phase. So you would consider it as just another tool for managing your lymphedema. Now there's a big wave of microsurgeries. I'm sure you've all heard about the lymphedema clinic led by Dr. Brown here at VGH. I'm not really going to talk about this too much now, but it's definitely coming more and more to the forefront, where they can do certain types of microsurgery that can assist with the lymphatic flow if you're the right candidate, depending on what your test results show. And test results mean an ICG test or lymphoscintigram to kind of assess what your lymphatics are capable of doing. Here's just a couple of my favorite resources. And just a few little references. And that is got my old email address on there. Gotta change that. So that's pretty much what I wanted to talk about. So I'm not sure if anybody has any questions.